Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
This is Lindsay Smith-Rogers. The CDC is again changing its isolation guidelines for COVID-19, reducing the amount of time those infected need to stay home after a positive test. Today, Stephanie Desmon talks to Johns Hopkins virologist Andy Pekosz about why the guidelines are changing and why it's imperative for those 65 and older to get another dose of the COVID vaccine. Let's listen.
Andy Pekosz, thanks so much for joining me again.
Oh, always a pleasure to be on.
So I wanted to talk today about these new CDC isolation guidelines we're hearing about. It used to be 10 days, and then it was 5 days, and now we have none?
Well, it's getting shorter. And I guess we could start by saying I think the CDC's main goal here is to try to make these guidelines consistent across a couple of different respiratory viruses. So we heard this year that things like RSV, influenza, COVID-19, a couple of these other viruses as well, all have a tendency to get you sick with respiratory symptoms. And the question is always, when am I ready to go back to work? And I think these guidelines are meant to try to be as broad as possible while maintaining some level of safety to ensure that you're not going back too early to spread infectious diseases. The guidelines are essentially, you want to wait 24 hours after your fever is gone or after your symptoms are starting to abate before you can think about going back to work. So it doesn't really tell you how long you have to be there. It just tells you what is the endpoint that you're kind of looking for before you can think about going back to work or going out to see people and stuff.
It does seem simple. It reminds me of when my kids were little and you had no fever for 24 hours before you go back to school. But it also makes me feel as though COVID is being grouped in with these other, it isn't the same.
Yeah, and I think that's one of the concerns that some scientists have about these guidelines. It's starting to treat COVID like influenza, like RSV, but we know that COVID-19 causes more serious disease, particularly in certain populations, more hospitalizations, more deaths than influenza and RSV. So, there's on one side, there's a fear that we're trying to diminish or we're not sort of emphasizing how serious a disease COVID is by lumping it in with these other still serious but not as serious infections.
Mm-hmm. Hundreds of people are dying every week still. And I saw a number of 20,000 hospitalized weekly. To me, that seems like something that you would go to greater lengths to prevent the spread of.
Yeah, and the CDC though emphasizes that a lot of that severe disease is happening in individuals over the age of 65 or individuals who are immunocompromised or have secondary medical conditions. So I think this guideline is really aimed at the vast majority of the population whose risk of severe COVID now is relatively low to the availability of vaccines, the fact that many people have gotten infected already. And so it's really aimed at that population. And I guess I would also add that the guidelines do say that when you go back to work, you should still practice for at least 5 days things like masking, social distancing, enhanced hygiene, washing your hands, washing the surfaces that you're working on. Because when you go back, you might have the potential to spread the virus still, and you should take that into consideration when you go back to work or when you go back to your normal daily activities.
So I've also heard some people say, well, the science of COVID hasn't changed. You still can spread it after your fever's gone, most likely, but the risk levels have changed. Can you explain how the risk levels have changed?
Yeah, because most of us have immunity now, severe disease after infection is dropping for all parts of the population, with the potential exception of the over 65 population. So I think that's really balancing that message to the general public in terms of the relative level of risk and what they should expect from that. I think many scientists would say also, though, that there's a better way to test out of isolation, right? And that's to use the rapid antigen test, because many studies, some of which my own lab has done, have really shown that the presence of infectious virus really correlates well with these rapid antigen tests. So a way to sort of use that as a way of coming out of isolation would be to simply say, wait for a rapid antigen negative test. And when you do have a rapid antigen negative test, go back to work with those 5 days of respiratory precautions and social distancing and those kind of things. But the CDC opted not to go for a test out protocol. They opted to go on something based on symptoms. And I think that's where the gray gets a little bit grayer, because there is this period while your symptoms are dropping where you can still be spreading virus.
Mm-hmm. And the antigen test is the one that I have a pile of in my living room.
Yep, absolutely. It's those home tests, those at-home tests that people have been using so effectively, I think, through most of the pandemic.
Yeah. My brother had COVID over the holidays, and he was trying to go somewhere, but that he wasn't going to be allowed until he absolutely tested negative. And it took him 2 weeks until he tested negative. Obviously, he would have been permitted to leave and go about his life much, much sooner than that. Would he also potentially have spread the disease?
Yeah, I think there would be a likelihood of that. If you're rapid antigen positive, there's a high likelihood that you're also infectious virus positive. Now, one of the things we don't know is how much virus you're spreading. So the risk may be lower, particularly if he was, for instance, vaccinated and had pre-existing immunity and those kind of things. But the risk would still be there. And so again, as a scientist, and I guess perhaps not thinking about the economics of this, a rapid antigen test to test out to go back to work seems to make a little bit more scientific sense, because it really is targeting that step where you're not infectious anymore. And that's really what we're looking for when we're getting people back into the workplace and into their daily activities.
So then people should be extra vigilant, perhaps, if you're immune compromised, if you're over 65. There's, I guess, a greater chance people could be out there with COVID and not taking precautions?
Absolutely. And I think the CDC guidelines do mention that, if you're in some of these high risk groups for severe COVID, you should be particularly cautious in terms of going out. They reemphasize the fact that everybody should be, even when they're not infected, practicing some of these respiratory guidelines, potentially wearing a mask if you feel comfortable doing so, and taking all those precautions, particularly when we know there are surges in either flu, RSV, or COVID-19.
So some critics have called this reckless. Would you say reckless is too strong of a word?
Yeah, I think reckless is too strong of a word. Again, the reality now is that people are, on average, infectious for shorter periods of time because of all of the pre-existing immunity that we have. So we need to start changing guidelines to think about COVID-19 as more of a seasonal threat, or sometimes people use the word endemic, which I know sometimes is hard to explain what that means. But, it's not a pandemic anymore. We're not seeing huge surges in cases, but we do know that certain parts of the population are vulnerable to severe disease. And we have to find that balance of allowing most of us to get back to normal and return to our activities, but also making sure that there's enhanced protection for those at-risk populations.
So I also understand the CDC is now recommending an extra dose of the COVID vaccine for those who are 65 and up. So if you're over 65, you should be getting another COVID shot. Is that right?
Yeah, and this fits into that. What can we do to protect the highly vulnerable parts of the population? And as you look at the numbers, particularly for COVID deaths and COVID hospitalizations, what really comes through is that the vast majority of people there are over the age of 65. And of those individuals, again, the vast majority have not had a recent COVID vaccine dose. So the CDC also just released some numbers showing that the most recent COVID vaccine does provide 50 to 60% protection from hospitalization and death across all age groups. So we know that the COVID vaccine is working, but we also know that COVID, again, as much as we'd like to make it think like it's like flu or RSV, it's not, because flu and RSV go away for long stretches of the calendar year, particularly sort of here in the Northern Hemisphere, right? But COVID hasn't yet gone away. We're always seeing cases of COVID. So I think we have to make sure ensure that the vulnerable populations maintain their immunity, their protection from severe disease across the year. And an extra dose of vaccine in that population should now get them over the next sort of 6 months and into a stage where we'd be expecting to see or have discussions about what the next formulation of COVID-19 vaccine looks like.
I was going to ask that, but before we move on to that, I'd like to know, or I'd like to talk about the fact that despite all of these warnings, despite all of the messaging, COVID vaccination is low.
Yeah, and it's a common public health mantra, right? Vaccines in a fridge or a freezer do us no good. We need vaccines in the arms. The elderly population has been better than most segments of the population in terms of getting the COVID-19 vaccine. I think it's upwards of 40% of individuals over the age of 65 have gotten the most recent COVID vaccine. But that's still too low. Again, it's better than the rest of the age groups, but it's still too low. And my fear is that number is just going to continue to decrease, even though the CDC has rather strongly phrased the fact that individuals should get this vaccine if you're over the age of 65 at this point in time.
Well, I'm going to, after we get off this call, I'm going to call my parents and tell them they need to schedule their next COVID vaccine. So what's next for the vaccine? You talked about a new formulation. I guess COVID continues to mutate.
Yeah, life in the laboratory continues to be incredibly busy. This virus is continuously mutating and showing us slightly different properties. As soon as a variant emerges and we start talking about it, subvariants or mutated forms of it also move around. I think it's important to note, though, that even though we have a new variant circulating now, laboratory studies have shown that the vaccine from the fall still generates some antibodies that recognizes this variant. So getting the vaccine will certainly boost your immunity to the variants that are circulating right now. But this JN.1 variant, and it's now moved on to other subvariants of that, is probably going to form the basis for a new fall COVID-19 vaccine. Again, this mirrors what we do with seasonal influenza. We update the vaccine every year based on what variants are circulating. The nice thing about the COVID vaccine, though, is that we can probably wait until May or so before we make a decision on what the fall vaccine is, because that mRNA technology is just faster than the way we make seasonal influenza vaccines. In fact, about 2 weeks ago, as of this recording, we already decided what next year's flu vaccine composition is going to look like. We're still seeing large numbers of cases of flu in the Johns Hopkins Hospital network and across the country, but we've already made the vaccine decision because we need that much time to make enough vaccine to distribute. We don't have the same problem with COVID, so that means our COVID vaccine for the fall will be updated, and it'll probably be much closer to what's circulating in the fall because that time needed to make the decision is much shorter.
But also, it seems like the variants are coming so much faster in COVID. Have we figured out sort of why this virus is so subject to mutation?
Yeah, it really does seem like particularly the areas that the virus uses to attach to cells. We call that the receptor binding domain. There seems to be just a lot of flexibility in what the virus can handle in that region of the protein. So it finds ways to evade antibodies that block that binding. A variant emerges that evades the antibodies, but maybe it doesn't bind so well to the receptor. But a few weeks later, another mutation occurs that makes it bind more tightly to the receptor. And a few weeks later, when people start generating antibodies to that new variant, they find yet another mutation that can evade the antibodies. Sometimes that weakens the receptor binding. So we go through this roller coaster with the virus where it's escaping immunity. That comes sort of at a fitness cost. The virus doesn't replicate as well for a short period of time, and then it figures out a way to improve its replication again. Again, the positive side, though, is that variants that are coming are out now. It's not as bad as when Omicron emerged, where basically most of the immunity in the population did not recognize the Omicron variant, and we were stuck in a place almost similar to the beginning of the pandemic where we had huge surges of cases. The variants now are making, incremental changes. They're getting a little bit better than each other. They're outcompeting each other slightly, but they're not going through those major changes that evade a lot of the pre-existing immunity. And this JN.1 variant is a good example of that. It has like 15 changes compared to the vaccine strain we use, but the vaccine still works against it. So we're hopefully getting to a place where because of population immunity, because of vaccination, we're much better protected against these variants, and the virus just doesn't have many new places to go because of all that immunity.
Andy Pekosz, thanks so much for joining me.
Thank you very much for having me.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmon, and Grace Ciceri. Audio production by J.B. Arbogast, Holly Cardinale, Spencer Greer, Matthew Martin, and Philip Porter, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media run by Grace Ciceri and Eliza Rosen. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.